Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 508 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, GBS is a 44-year-old African-American woman whose weight is 175 pounds, and height is 5 feet, 5 inches, with a 20-year history of type 2 diabetes mellitus. She presents to the diabetes clinic for her quarterly checkup. She has been non-compliant with regular appointments, and her blood glucose has generally remained greater than 200 milligrams per deciliter on prior evaluations, with a hemoglobin A1C of 10.1% 2 months ago. The goal is below 7%. Lately GBS complains of general nausea, malaise, and poor appetite. She has been treated for peptic ulcer disease for the past 6 months. The workup reveals the following pertinent laboratory values. Serum sodium levels of 143 milliequivalents per liter. Potassium levels of 5.3 milliequivalents per liter. Chloride levels of 106 milliequivalents per liter. A bicarbonate content of 18 milliequivalents per liter. A serum creatinine of 2.9 milligrams per deciliter. A BUN of 63 milligrams per deciliter. And a random blood glucose of 289 milligrams per deciliter. Physical examination reveals a blood pressure of 160 systolic, 102 diastolic, 2+ pedal edema, and mild pulmonary congestion, and a 10-pound weight gain. Additional laboratory studies show the following results. Serum phosphate levels of 6.6 milligrams per deciliter. Calcium levels of 8.8 milligrams per deciliter. Albumin levels of 3.6 grams per deciliter. Magnesium levels of 2.8 milliequivalents per liter. Uric acid levels of 8.8 milligrams per deciliter. Hematologic studies show the following results. A hematocrit of 28%. A hemoglobin of 9.3 grams per deciliter. White blood cell count of 9,600 per microliter. And a platelet count of 155,000 per microliter. RBC indices are normal. GBS's reticulocyte count is 0.5%. Her urinalysis showed 4+ proteinuria, later quantified as a urinary albumin of 700 milligrams over 24 hours. So my question to you reads, what subjective and objective data in GBS are consistent with a diagnosis of advanced kidney disease? GBS's abnormal values for serum creatinine, BUN, serum potassium, magnesium, phosphate, uric acid, bicarbonate content, hemoglobin, are all consistent with kidney disease and its associated complications. Assuming relatively stable kidney function, i.e., no acute changes in kidney function, her eGFR is approximately 21 milliliters per minute per 1.73 meters squared based on the MDRD equation, placing her in CKD category 4, that is an eGFR of 15 to 29 milliliters per minute per 1.73 meters squared. As the eGFR declines to the degree observed in GBS, normal regulation of fluids and electrolytes is impaired. Elevations in serum creatinine, BUN, sodium, potassium, magnesium, phosphate, and uric acid as well as signs of fluid accumulation are observed. GBS's serum potassium is slightly elevated and the risk of hyperkalemia increases with CKD. The substantial degree of proteinuria observed in GBS is consistent with advanced glomerular damage. Volume overload from continued intake and decreased sodium and water excretion leads to weight gain, hypertension, and edema. Metabolic acidosis results from impaired synthesis of ammonia by the kidney, which normally buffers hydrogen ions and facilitates acid excretion. Anemia associated with CKD is caused primarily by decreased erythropoietin production by the kidneys, but it also can be caused by shortened half-life of RBCs from uremia and iron deficiency. GBS's recent onset of nausea and malaise may be a consequence of the accumulation of uremic toxins, azotemia, from the decline in kidney function. My next question to you reads, what is the cause of GBS's advanced kidney disease? Given GBS's presentation, her kidney disease is most likely caused by diabetic nephropathy from her 20-year history of type 2 diabetes mellitus. Poor compliance with regular appointments, elevated glucose concentration and hemoglobin A1C values, and albuminuria serve as the primary cause. Diabetic nephropathy rarely develops within the first 10 years after the onset of type 1 diabetes. However, 5% to 20% of patients with type 2 diabetes have some degree of albuminuria at diagnosis. The annual incidence is greatest after approximately 20 years duration of diabetes and declines thereafter. GBS fits this pattern in that she has diabetic nephropathy after a 20-year history of diabetes, although her nephropathy was likely evident several years previously. African Americans, Native Americans, and Hispanics have an increased risk of developing ESRD from diabetes mellitus relative to whites. Diabetic nephropathy is a microvascular complication of diabetes mellitus resulting in albuminuria, hemodynamic changes in kidney microcirculation, glomerular structural changes, and a progressive decline in kidney function. Diabetic nephropathy develops in approximately 1/3 of all patients with type 1 and type 2 diabetes mellitus. Because type 2 diabetes mellitus is more prevalent, these patients account for most diabetic patients starting dialysis. With the increased prevalence of diabetes and the increase in life expectancy of this population, it is likely that diabetic nephropathy will remain the leading cause of ESRD in the United States. Whereas most research has focused on the pathophysiology, prevention, and treatment of diabetic nephropathy in type 1 diabetes mellitus, it is reasonable to extrapolate available evidence on prevention of diabetic nephropathy to the population with type 2 diabetes mellitus. The exact mechanisms leading to the development of diabetic nephropathy are not clearly defined. However, several predictive factors for the development and progression of kidney damage have been identified. These include elevated blood pressure, plasma glucose, glycosylated hemoglobin, and cholesterol, smoking, advanced age, male sex, and, potentially, high protein intake. Insulin deficiency and increased ketone bodies have also been proposed as contributors to the pathogenesis. Advanced glycosylation end products, abbreviated as AGE, that form in conditions of hyperglycemia have also been implicated as a cause of end organ damage. The accumulation of multiple advanced glycosylation end is associated with the severity of kidney disease in patients with diabetic nephropathy. A genetic predisposition exists in that higher rates of diabetes mellitus and nephropathy, hypertension, cardiovascular events, albuminuria, and elevated blood pressure have been observed in relatives of patients with type 2 diabetes mellitus. Certain genes and polymorphisms have also been associated with the development of diabetic nephropathy, and further exploration into this area may prove beneficial in identifying high-risk patients. My next question to you reads, what is the significance of GBS's albuminuria? Albuminuria, the earliest sign of kidney involvement in patients with diabetes mellitus, correlates with the rate of progression of kidney disease. Albuminuria not only indicates renal damage but is also a powerful predictor of cardiovascular morbidity and mortality. For most patients, eGFR begins to decline once proteinuria is established. Because of this association, annual testing for the presence of microalbuminuria is indicated in patients who have had type 1 diabetes mellitus for more than 5 years and in all patients with type 2 diabetes mellitus starting at diagnosis. The presence of albuminuria indicates irreversible kidney damage. GBS has likely reached the point at which such damage is inevitable because her urinary protein exceeds ranges normally observed at the earlier stages of kidney disease. GBS's current laboratory data suggest that she has substantial kidney disease and has developed associated complications of the disease. Although progression to ESRD is generally beyond prevention at this stage, appropriate intervention can slow the progression to ESRD for GBS. Progressive diabetic nephropathy consists of proteinuria of varying severity, occasionally leading to nephrotic syndrome with hypoalbuminemia, edema, and an increase in circulating LDL cholesterol as well as progressive azotemia. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 509.